Good morning, everyone, and happy Friday. It is so good to see everybody. It's fantastic to also see David and Catherine on. So good morning, David and Catherine. So glad to see y'all. This morning, we are so excited to have Dr. Stuart Altman back with us for round two. Just a couple of quick announcements before we begin. The first is a reminder that there will be no Friday facts the first 2 Fridays of July due to the 4th of July holiday. We've also canceled the July monthly coalition meeting and will reconvene back again in August. Also, we are so excited to share that the coalition's progress report is finalized and was sent out earlier this week and is also posted to the website. I'll make sure to post that link in the chat, and feel free to reach out if you have any questions or trouble accessing it. And lastly, just make sure to put your name and organizations in the comment box and post any questions that you have for Dr. Altman, and we'll address them as we go. And with that, Heather, I'm going to pass it over to you. We're excited for this father-daughter interview. It's the first of its kind. So let's go ahead and start.
Well, thank you, Virginia, and thank you. Welcome to Dr. Stuart Altman. Yeah, Dr. Stuart Altman is the Saul C. Chaikin Professor of National Health Policy at the Heller School for Social Policy and Management at Brandeis University. Lesser known, but more important fact for this group, he also is part of the adjunct faculty in health policy and management for the University of North Carolina at Chapel Hill. So he is one of our own. Goes by Dr. Stuart Altman, Professor Stuart Altman. Yes, I prefer to call him Dad. So can't promise what I'll be calling him during it, but welcome, Stuart.
Oh, thank you. This is really exciting.
Now you have the honor, as Virginia said, and many folks know, you are part two. You were interviewed a few months ago by David Sevier, and we only got through basically the mid-70s. So we're excited to have part two and welcome you back. Because this is part two of an interview, generally we ask folks to hold their questions till midway, but you don't need to hold back, friends. If you have questions, I have my own. Clearly, I'm going to pummel my father with questions, but please add them in the chat line. So Dad, I feel like we need to be our own Netflix and do previously on Friday Facts with Dr. Altman. Super quick for you and for our audience. In our last interview, I'll say very quickly, you took us through your childhood in the Bronx, your education in New York, grad school at UCLA, your journey from being a labor economist to studying women in the labor force, which brought you to the study of nurses, and by that, your accidental involvement in healthcare, which took you to the federal work at the Pentagon, then HEW as the Deputy Assistant Secretary for Health. And then we kind of had to pretty much stopped there and then had to kind of go through the next very quickly. So we now want to pick up over the last 40 some odd years. And I will ask and say one of the highlights of your bio, and I know one of the highlights of your career, has been a part of at least five different presidential administrations. So as you pick up from your background, start us with the Nixon administration. What was it like and what has it been like to be in these different roles?
Well, first I want to make it clear, even though I technically was a political appointee, I was not very politically involved. I like to think of myself today as being at least somewhat knowledgeable, if not a professional in the political world, but in the 1970s, I was very politically naive. How I wound up in the Nixon administration, I don't talk about unless I've had a few drinks. You maybe have heard me speak about it, Heather, but there I was in 1971 in a position very different than today, in the sense that there was a handful of really senior people in Washington that were involved in healthcare. Now they're in the thousands. And it turns out, and of course, I had no background in health. So as far as I was concerned, healthcare in America started in 1971, which is when I was there. I did reading a little bit after that. And it turns out, other than maybe the mid 1960s and maybe the Affordable Care Act, the early 1970s was a very, very exceptional period, a lot of activity. First of all, one of the things I did was to chair the what used to be called the Cost of Living Council. And I'm probably the only American that has regulated healthcare costs at the national level. And I did that from 1972 to 1974. So I was very involved in things like creating what became known as the HMO Act, which created health maintenance organizations all over the country. I helped expand the number of physicians trained in, we doubled the number of physicians trained in America. We got very much involved in national health insurance, and the model that my team put together, which was put out by Nixon, became the basis for then the passage of health reform in Massachusetts, and actually is very much similar to the Affordable Care Act. So I was involved in a lot of pretty important stuff in the early and mid 1970s.
Then take us through what happened after that. So then what happened?
Yeah, I got
You're
out.
still important, don't get me wrong.
I got out just before I was thrown out in 76 and wound up becoming the dean of the Heller School at Brandeis in 1977. And in 1981, the Reagan administration decided to restructure how it paid hospitals. And it created what's become known as the DRG, or diagnostic related grouping system. And it's a very complicated way of paying hospitals. And they created a commission to advise both the president or the administration and the Congress, called PROPAC. And out of, I don't know, some strange force, they asked me to become its chair. And so I was chair of PROPAC from 1983 to 1994. And it still is the structure by which hospitals are paid, and has had a tremendous impact on the whole structure of the healthcare delivery system. And that was a pretty heady period as well. And I've been still involved with the DRG system as it has expanded since then.
So we may jump more into that, but then take us through, then now we're in the 90s. I feel like the Clintons are coming into this conversation soon.
Oh, the Clintons. So you may remember Bill Clinton, he ran on a platform in the early 1990s to have true healthcare reform. During the Nixon administration, he got a little problem. He resigned, and the head of the Ways and Means Committee, Wilbur Mills, got in trouble with Fannie Fox, and healthcare reform went away. Just shows you how things can be so important and then gone. Anyway, Clinton got involved in the early 1990s, and he set up a transition team as he was being, he had already won the election. And the head of the transition team was a friend of mine, a graduate of Brandeis. And she asked me to come down to Washington, and in the period from Thanksgiving to about January 20th. And I tell you, it was a 24/7. I went from being the youngest kid in the room to the oldest kid in the room between 1974 and 1992. Anyway, the Clintons were all excited about health reform. And Hillary Clinton, if you remember, became in charge. But as the transition team was breaking up, and you can read about this in my book if you want to get a copy, you can probably buy it cheap. My students probably send them down. Anyway, they were all excited about this health reform, And I had the temerity to say, Mr. President, don't do it. Yeah, America is not going to accept a radical change in their health system. And he put his arm around me and he said, Stuart, you're a great American. And I was thrown out of the administration. Hillary Clinton then called me back several months later and asked me to come in. But I said, you know, what you're doing isn't going to work. And of course, it didn't work. And it became a gigantic mess and helped elect a really Republican administration in 1996. So but I did stay involved. And then when in 1997, we passed the Balanced Budget Act, and there was a commission set up to review the future of Medicare. And President Clinton appointed me as one of the members. So from roughly I guess it would be 1999 until early 2000, I was involved in this commission on the future of Medicare while I was the dean of the Heller School.
Right. So, yeah, so you did have the distinction of being, I think, right, the first person fired from the Clinton administration
before I got hired. So, yeah.
All right. So then well, now we're in my lifetime, so I can say in more recent years. So then going through what happened with the Obama administration, passage of Affordable Care Act, what was your involvement with the more recent administrations being, you know, within the last 25 years?
Well, I got involved very much with Senator Kerry as he ran for president. As a matter of fact, I was tapped to head the Medicare program, and it looked like he was going to get elected. And I don't know if you know this, Heather, but your mother and I, on the night of the election, were sitting having dinner right across the street from where the Kerry people were going to having their big event in Boston, and thinking about whether we should, you know, rent our house, sell our house. What are we going to do when we move to Washington? And as that dinner proceeded, I got a few phone calls saying, I don't know, things don't look too good. And needless to say, I didn't have to sell the house. But because I got involved with the Kerry people, when Obama ran for president, they tapped me again to sort of be a bit of an advisor during his transition. I didn't have to go to Washington, but was involved in a couple of important meetings in terms of establishing the parameters of what became the Affordable Care Act in 2010. So I stayed very involved in Washington, even after the end of PROPAC and the end of the Medicare Future Commission.
I was thrilled, by the way, that you didn't get that position and you didn't go to DC, because I've always been a bit protective of you. And I was like, well, no, that's too big a position. And then people might say mean things about you. And so I was thrilled. Sorry. So, and, you know, glad you didn't have us move yet.
Well, okay. Well, I stayed involved and then got much more involved in state activities. And the most important one was Governor Dukakis, and Massachusetts created what became known as was the first and now the most popular form of cost containment, and created what became the Health Policy Commission in 2012. And I've been its chair ever since. I then was reappointed by the Republican governor, and I'm now sort of finishing my tour there. But it's turned out to be quite an effective mechanism for slowing the growth in health spending, and it's been adopted by at least a half a dozen other states around the country. So I'm still active in Massachusetts, although my home now, as you know, is in Chapel Hill, North Carolina.
Well, and it's one of the things that I was curious about. And so I thought, rather than asking around the dinner table, I'll ask with a bunch of friends watching. So you've then straddled going from federal work on the national level and then super involved on state level work, especially in Massachusetts. How is one more exciting? Do you feel like you can have a different impact? What does that feel like to go and give your focus to one state versus all of them?
Well, when I was in Washington, and I didn't even know we had states, you can get really caught up in your own importance in Washington, and you tend to think about states as being, those little kids running around with scooters. But the reality is, now that I've been very involved at the state level, is so much more is going on at the state level. You really get into the actual delivery. When you're in Washington, as I said, you round to the nearest $10 billion. You're not touching people. But when you're at the state level, you're very involved in what's going on around the corner. You're around your local, whether it's your mental health institution or your hospital or the physician practices. And so I've become much more involved with states. And not only that, Washington is paralyzed in a lot of ways, and is much more, I find my involvement in Massachusetts much more interesting today than my friends who are in Washington, who are very discouraged.
So building off of that and thinking now your other home here in North Carolina, we've got a great question from your good friend and mine, Tom Akins. So Tom just sent, because so many of us here work in North Carolina, the question is, we can't help but be struck by your tenacity, sticking with things through different administrations and political societal changes. What would you tell us as advocates in terms of staying motivated through the ups and downs of advocacy?
Well, good question. Yeah, stick with it is probably, you have to decide, in North Carolina, I'm not nearly as involved as many of you are. From my vantage point, there are 3 or 4 big things. One clearly is the whole Medicaid. I mean, I'm sorry for those of you who may have a different point of view. I think it's a disgrace, quite frankly, that this state has not expanded the Medicaid coverage and is leaving literally hundreds of thousands of North Carolinians without coverage. So I put that very high on the list. Given Tom's orientation, my sense is that there are some serious issues in long-term care in not only North Carolina. I think my view is that of all of the problems we have in healthcare, the one that is in many respects the most serious, both at the financing level or coverage level and in the delivery level, is long-term care in America. In a lot of ways, and I don't want to be disrespectful, but it's really a middle class problem. As bad as care is for people at the low end, they are protected somewhat, even in North Carolina, from Medicaid. And then you got the rich who can decide what they're going to do. But the middle class is caught. So on the coverage side, it's a real problem we've not dealt with well. Well, we haven't dealt with it all. And then on the delivery side, there are lots of problems. And now with the COVID and the staffing, so I would put that as clearly number 2. And number 3, which is the area that I focus the most on, you have a growing group of monopoly delivery systems in North Carolina. And of course, they will always tell you that they're expanding to increase quality and lower costs, become more efficient. But the research is so strong that these monopoly delivery systems actually become less efficient, more expensive, and often less responsive to the needs of the patient. So, you've got three or four big delivery systems here, including Duke and UNC, Wake Med, and that's a problem. And you've had some wonderful secretaries of health. I give them a lot of credit for what they've done, but you got a long way to go. So those would be, from my vantage point, looking from afar, three areas that are deserving. And of course, the nursing shortage. I haven't talked much about my career in nursing, and I know you have a number of nurses in the group.
All right, go into it. Catherine, we prepped him. He knows. All right, Dad, go into nursing, and then we'll get a few more questions in there.
Well, as I indicated last time, my fluky background about women in the labor force got me involved with the Nurse Training Act in 1967. Just like I told you about the physicians, to expand the number of nurses. And we got into this whole big issue about ending diploma schools and sort of creating the associate degree program. And then I kept being asked, the Institute of Medicine, or the National Academy of Sciences in medicine, kept putting me on nursing commissions. I was the economist to try to deal with it. And then most recently, it's probably 3 or 4 years ago, I was on the commission funded by the Robert Wood Johnson Foundation from the Institute of Medicine, looking at whether we should go to all baccalaureate trained nurses and phase out not only diploma nurses, but also associate degree, and move them up. And I've also been involved with expanding the scope of practice of nurses, and gotten involved in that whole big debate between the advanced nurse practitioners and many of the physician groups on how much independent authority an advanced nurse practitioner, or physician assistant for that matter, should have vis-a-vis physicians. So it's become an important issue that I've been very much involved in. And I've been in my role as chairman of the commission in Massachusetts, I helped push hard for expanding the scope of practice in Massachusetts for advanced nurses.
So we have just a few minutes left. I know there was a question, which I'm going to merge into my question, about what's going on in healthcare policy today. I'll broaden it a little bit to say, Dad, I know you do a tremendous amount of teaching. You have students from 19 to, well, 59 with all your courses. What's the one thing you really want them to take away to understand and do good in the health policy arena? Or what's one of them?
Well, I don't think there is one, but the thing being an economist, I focus a lot about the cost of healthcare and how whether we have the whether we're going to continue to support it. It's approaching 20% of our GDP. Even though we have coverage more, we still have over 10% of our population uninsured. And for a lot of others, they're underinsured. So on the one side, we have a coverage problem. And on the other side, we have a very expensive healthcare system that, while it provides technically good quality care, and I don't fault that, when you really look at our health system as opposed to our healthcare system, we don't do that well. I mean, when you compare how long we live compared to countries and other countries, we're way down and we're actually declining. The amount of illnesses in a lot of areas is is approaching, in some sense, third world countries, which is really terrible. So we have delivery system problems and financing problems. And we have a lot of problems with duplication and services on the one hand that don't need to be done and services that aren't being done. So the good news for those of you who are going to be around for the next 20 years, you're going to have a lot of work to do. For those of us who've been doing it for the last 50 years, shame on us. We haven't solved these problems.
All right, so look, I'm already getting chat comments about how we're going to need a round 3 with you. So let's see, 2 quick questions left. Another one that came in the chat line. Dr. Altman, you worked on the 1970s Federal Qualified HMO Act, which set parameters for comprehensive coverage and fair pricing. By the 1990s, most emerging managed care diverged greatly from this and segmented markets. Do you have any reflection on how we move back towards community rating and comprehensive coverage?
Oh, good question. That's somebody who really knows the issue. So, you know, the HMO Act was one of the acts which was bipartisan, but the Republicans had a view that you should have 1,000 flowers bloom, as they called it. And HMOs could be all under that tent. You could have all different kinds of organizations. The liberals under Senator Ted Kennedy wanted to use that as a mechanism to have a single payer system, very comprehensive community rating in the sense that everyone paid the same amount. And these two forces collided. And then we had the takeover of HMOs, mostly by insurance companies. And then we had the 1990s where we really did move into, you know, Clinton wanted everyone to be under them. Unfortunately, there was a tremendous backlash during the 90s against managed care. Some of it was justified and some of it wasn't. But the net impact by the end of the 1990s was that managed care and HMOs were kaput. There were a few of them that stayed around in California, and we have some in Massachusetts and here and there. But the model of the true organized delivery systems with capitated payments really fell apart. And while we have bits and pieces of them around the country, for the most part, they are not nearly as effective or available as we had thought back in the 1970s. So we're back to a fee-for-service system with bits and pieces all over the place.
All right. Well, so we have to close in just a few moments. I'm torn between my last few questions, but you did, you know, talk about trying to get everyone under the tent before in terms of coverage. So we are the North Carolina Serious Illness Coalition, and that is our focus. And next, in the next few weeks, next month's a big anniversary for you and for me. It'll be 3 years since your own major serious illness. And so as in terms of reflections on how your dance with incredible intensity and your spa stay at the ICU for a while, any reflections on how that affected you both personally or how that affects your professional view moving forward for those of us in the professional space of serious illness and you who's still in the professional space?
Well, at the one level, I try to separate them out because I did develop a serious illness and I still don't know how I got it. And it's an illness that often is caused by less than sanitary conditions in the hospital. So it may have been caused by the hospital itself. On the other hand, when I was, as you know, I was in the ICU for 6 or 7 weeks, and I really got wonderful care. So this hospital that almost killed me, on the other hand, saved me. I think you know this. I mean, I'm not the same person I was before, but I try to persevere. I've been fortunate to have, and I will say this to everyone, you around to keep me going. People may not know, I mean, this young lady is just incredible in terms of being a caregiver, as well as someone who keeps an exciting life, you know, every day.
All right, keep it on you. Love me more at dinner. Let's keep the focus on you. I hog the spotlight enough, but so in terms
Well,
of
anyway, the net
personal-
impact of all this is that as I said, I see the ups and downs of our delivery system, and but I try not to, you know, I'm still focused on the issues I was focused on before, with a little bit of what you know, a little understanding, a little more deeply about the good and the not so good of our health system.
Well, with that, Dad, thank you so much, and we're getting lots of thank yous, and you're fabulous and amazing, and you rock on the chat line. And clearly, I think you're going to be the first person to come back for round 3.
Well, I want to thank you all for giving me this up. There's nothing better for an old guy than telling stories, and I love it.
Well, thank you to Dr. Stuart Altman. Thank you to the coalition members. We will see you in a few weeks. Stay healthy, and again, many thanks to all of you.
Bye now.